Welcome to the Funnel Effect. Today, we're diving deep into a really challenging area of cardiovascular intervention. We're talking about the place where complex procedures get even more complex. Specifically, we're looking at the intersection of chronic total occlusions, CTOs, and bifurcation lesions. These are two of the most technically demanding situations interventional cardiologists face. Think of this deep dive as your shortcut to the expert playbook for handling these incredibly high-stakes procedures. We're drawing directly from a major state-of-the-art review. It's titled CTO and Bifurcation Lesions, an expert consensus from the European Bifurcation Club and EuroCTO Club. This was published in JCC. Cardiovascular Interventions, Volume 16, Number 17, back in 2023. And the insights come from top minds in the field, including the primary authors, Dr. Thierry Lefebvre and Dr. Manuel Pan, along with their many esteemed colleagues. So our mission here is pretty straightforward, but absolutely vital. We want to synthesize the core strategies, the essential do's and don'ts these experts agree on, especially focusing on how to successfully open that blocked main vessel, the CTO, while, and this is critical, keeping those important side branches safe and sound. This consensus is, well, invaluable for anyone involved in these complex PCIs.
It really is. And, this consensus didn't just appear out of nowhere. It came from a real need. Like you said, tackling a CTO is already a huge technical challenge. You've got an artery that's been 100% blocked for, well, usually months or more. It requires very specific skills, specialized wires, catheters. Now, throw a bifurcation into the mix, that point where the main vessel, the MB, splits and involves a significant side branch, the SB. You're instantly making a difficult procedure exponentially harder. And it's not just about making it take longer. It adds a serious layer of risk to the whole thing. The source material really hammers this home. Managing that risk, particularly the danger of damaging or losing that side branch, is absolutely key for good long-term patient outcomes. A lot of the battle happens, in that tricky subintimal space, trying to get the main artery open without plaque shift or dissection, essentially crushing the side branch. It's a delicate balance.
Okay, let's talk about how often this actually happens. Because it's not some rare, obscure problem, is it? The data shows it's surprisingly frequent. Bifurcation lesions, specifically those with a relevant side branch, turn up in about 1/3 of all CTO PCI cases.
Yeah, roughly a third. It's quite common.
Now, I saw there's some variability in the numbers reported, maybe 26% in some studies, up to almost 47% in others, but the bottom line seems clear. This is a common complexity.
Exactly. The range reflects different patient populations, maybe how relevant the SB was defined, but yeah. If you're doing CTOs regularly, you're going to encounter this combo, a lot. Maybe 1 in 3, maybe closer to 1 in 2 cases.
You absolutely need a game plan from the start.
You do. And that game plan really depends heavily on where that bifurcation is located relative to the blocked segment, the CPO itself. The consensus authors did a great job breaking this down into 3 main locations, and each one brings its own specific challenges and dangers.
Okay, let's walk through those.
Right. So first up, you have the bifurcation at the proximal cap of the CTO. This happens in about 35% of cases. The big problem here is what's called proximal cap ambiguity. Because the blockage starts right where the side branch takes off, it's really hard for the operator to know precisely where the true lumen of the main vessel begins.
So finding the right entry point is the challenge.
Exactly. If you guess wrong with your initial wire puncture, you might immediately go subintimal outside the true vessel path. And going subintimal, right at the start, near that SB, well, that's setting yourself up for potential trouble down the line. We'll talk more about why that's bad later.
Okay, that's the proximal cap. What's next?
Next, and this is the most common spot, roughly 38% of the time, is the distal cap.
So the bifurcation is right where the CTO ends.
Precisely. Think about the very end of the right coronary artery, the crux, where it splits into the PDA and the PL branches. That's a classic example. This is notoriously difficult because, okay, let's say you successfully cross the entire CTO. Boom, you land right in the middle of this complex split.
So the landing zone itself is the problem.
Yes. The risk is that the very act of opening the main vessel, or especially stenting it, can compromise one or both of those crucial distal side branches. You might fix the CTO, but lose the vessels it was supposed to supply. It's a high-wire act.
Right, potentially losing 2 branches to save 1. That leaves the third location, the one that just sounds the most complicated, the bifurcation within the CTO body. That's about 27% of cases. What makes that the toughest?
Well, it sort of combines the worst of both worlds. You've got all the usual challenges of crossing a CTO. It might be long, calcified, twisty. Plus, you have this side branch originating right from the middle of that hostile territory. The consensus paper actually points out that having a bifurcation within the CTO body is an independent predictor of, well, procedural failure and higher complication rates.
Why specifically?
Couple of reasons. First, the plaque blocking the main vessel might extend right into the origin, the ostium, of the side branch in unpredictable ways. Second, any attempt to cross the CTO using extra plaque techniques going outside the true lumen is very likely to compromise that SB origin.
Especially if that SB is important for blood flow.
Exactly, especially if it's providing vital collateral circulation. Now, there is maybe a small upside sometimes. If you can see and wire that side branch early, it can serve as a kind of landmark within the CTO body.
Ah, like a signpost to the blockage.
Sort of, yeah. It can help orient you, but generally it's the most complex scenario.
But the message seems consistent across all three locations, proximal, distal, within the body. The absolute priority, the consensus says, is preserving the integrity of that side branch. Why is saving the SB so critical, even if the main target is the blocked MB?
Because that side branch might be supplying a significant area of heart muscle that's still alive and kicking. The goal isn't just to, technically open the main pipe. It's about improving the patient's symptoms, their heart function, their overall prognosis. If you successfully open the CTO but sacrifice a major relevant side branch in the process, you might actually worsen the patient's situation or negate the benefit. You could even cause a heart attack, a periprocedural MI, which has serious long-term consequences. So, protecting that SB isn't optional, it's fundamental to the definition of success.
Let's dig into those consequences. You mentioned losing the side branch. How often does that actually happen, and what are the real costs? The numbers seem quite concerning. SB occlusion during CTO procedures isn't rare. The reported rates vary quite a bit, but they range from about 8.6% on the low end up to a really worrying 25.7%.
Yeah, that upper range is sobering.
It suggests that in some situations, maybe depending on the anatomy or technique, almost a quarter of these complex procedures could end with the side branch being lost. And the clinical fallout is what really matters here. The consensus is clear. Losing a relevant SB is directly linked to a higher rate of periprocedural myocardial infarction, a heart attack during or right after the procedure.
Correct. And that's not just a temporary setback. That MI damages heart muscle, impacts how the heart remodels and functions long term, so it directly affects the patient's future health and survival.
Now, is it always a disaster if the SB occludes?
Well, the paper acknowledges that sometimes the clinical impact might be limited. Maybe the area that branch supplies already has dead tissue, non-viable myocardium, or maybe there's really good collateral blood flow coming in from other arteries.
So sometimes you get lucky.
Sometimes. But the key point from the experts is you absolutely cannot plan on getting lucky. You can't assume the SB doesn't matter. The risk of causing an MI, even if it's not guaranteed, is just too significant.
So the default approach must be protection.
Absolutely. Proactive strategies to protect that SB have to be part of the plan from the very beginning whenever a relevant branch is involved near the CTO.
Okay, so if we need to protect it, what are the main things that make it harder? Which techniques increase the risk the most? The consensus seems to point fingers squarely at dissection and reentry methods.
It does, very strongly. Probably the biggest single factor driving SB loss is the use of dissection and reentry techniques, whether antegrade or retrograde. These techniques involve intentionally creating a path outside the true lumen in the subintimal space to get around the blockage. While they can be very effective for opening the main CTO vessel,
They come at a price for the side branch.
a potentially very high price, yes. Compared to achieving a clean lumen-to-lumen wiring dissection and reentry, significantly ramps up the risk of losing the SB and causing that periprocedural MI.
Can you explain the mechanism? Why does going extra plaque cause this?
Sure, so when you track extra plaque, you're essentially creating a new channel by separating the inner lining of the artery, the intima, from the middle layer, the media. You're in the wall of the vessel. Now, when you inflate a balloon or deploy a stent within this newly created subintimal space, you're applying significant force to push the plaque and the vessel wall around.
Remodeling that space.
Exactly. This creates a sort of flap of tissue, the dissected intima and media. If this happens near the bifurcation, that expanding flap, or just the pressure from the balloon or stent, can physically shift or compress the origin of the side branch.
Like closing a door on it?
Precisely. It can act like a guillotine, crushing the SB ostium or completely sealing it off. And once that flap is created and pressurized by a stent, it can be incredibly difficult, sometimes impossible, to get back into that SB.
So avoiding extra plaque tracking near an important SB is rule number one.
It's a fundamental principle woven throughout the entire consensus document, yes. If you can stay lumen to lumen, your risk to the SB is much, much lower.
Beyond the dissection flap itself, are there other risks specific to CTO procedures near bifurcations? What about the equipment?
Yes, definitely. The risk of coronary perforation making a hole in the vessel is generally higher in CTOs anyway because of the techniques used, but it's particularly elevated when you're using aggressive dissection strategies near a bifurcation, or if you accidentally advance one of those stiff, pointy CTO wires too far down into the side branch. It doesn't take much to puncture the wall, especially if the SB is small or diseased.
Okay.
And then there's the ultimate nightmare scenario, the one that keeps interventionalists up at night, when the bifurcation involves the left main artery.
The artery supplying the majority of the left ventricle.
Exactly. If you end up tracking subintimally proximal to the left main bifurcation, where it splits into the LAD and circumflex arteries, the resulting dissection or hematoma, the blood collecting in the wall, could suddenly shut down both of those major arteries at the same time.
That sounds catastrophic.
It is. It's often immediately fatal unless you can get the patient onto emergency bypass surgery or mechanical support within minutes. This is why the left main bifurcation is considered an absolute no-go zone for extra plaque tracking. You just don't do it.
Understood. Now, a more common, perhaps less dramatic, but still important mechanical issue is SB material jailing. You've placed a protective wire in the SB, stented the main branch over it, and now that wire is trapped. What's the specific danger when removing it?
So jailing the wire is almost routine in bifurcation stenting. The wire gets trapped by the stent struts. The immediate danger isn't usually the wire being stuck itself.
It's getting it out.
It's the potential complication while trying to get it out, specifically the risk of causing a proximal coronary dissection, tearing the artery near its origin.
How does that happen?
If the jailed wire gets snagged on the stent struts as you're pulling it back, and you apply too much force without stabilizing the guiding catheter.
A whole catheter could jump forward.
Exactly. The force can inadvertently pull the guide catheter deep into the coronary ostium or cause its tip to dig into the vessel wall right at the entrance. This can cause a new, dangerous tear or dissection, often far more proximal and problematic than the original lesion.
And this is where that specific technique, left-hand control, comes in.
Correct. It sounds simple, but it's crucial. The left hand, typically the operator's non-dominant hand, maintains firm control over the guiding catheter, keeping it stable at the coronary ostium. So if you feel resistance when pulling back the jailed wire, the guide catheter doesn't jump forward, it stays put. This simple maneuver prevents that forceful guide engagement and dramatically reduces the risk of causing a new iatrogenic dissection at the ostium. It's basic, but absolutely critical safety practice.
Okay, we've covered the risks and complications. Let's pivot to the recommended strategies for actually doing the procedure. Given how complex and often lengthy CTO interventions already are, it sounds like the expert consensus really leans towards keeping the bifurcation part as simple as possible.
Absolutely. Simplicity is key whenever possible. The default go-to strategy recommended for handling a bifurcation encounter during a CTO PCI is provisional stenting.
Meaning you plan to stent only the main branch initially?
Exactly. You focus on successfully opening and stenting the main CTO vessel. You place a protective wire in the side branch, of course, but you don't plan to routinely stent that SB unless you get a suboptimal result after stenting the main branch, like slow flow, a major dissection, or pinching of the SB origin.
And the evidence supports this approach.
Yes. For most non-CTO bifurcations, numerous studies have shown that provisional stenting gives results that are just as good as, or even better than, routinely using two stents right from the start. And in the context of a complex CTO, the desire to avoid adding more complexity strongly favors the provisional approach. You want to get the main job done efficiently and minimize extra steps near that sensitive bifurcation zone.
This philosophy leads directly into what the consensus calls the simple rules for prevention. It seems like these rules are designed precisely to increase the chances that the provisional approach will be successful, right? To avoid needing a complex two-stent bailout later.
That's exactly the idea. These are 4 key principles aimed at preventing SB compromise in the first place.
Okay, what's rule number 1?
Rule 1, wire early. As soon as you can clearly see the side branch angiographically, get a guide wire into it for protection. Don't wait.
Why so early?
Because securing access early is crucial. It confirms you can get into the branch, it stabilizes the anatomy somewhat, and it acts as a marker. If you stent the main branch first and then find you can't get a wire down the SB because the origin is now pinched or dissected, well, you're already in trouble. Wiring early avoids that scenario.
Makes sense. Rule number 2.
Rule 2. Respect fractal anatomy. This is about stent sizing, specifically using the 3-diameter rule.
Okay, what does that mean in practice?
It means you should choose the diameter of your main vessel stent based on the diameter of the vessel distal to the side branch takeoff, not the usually larger diameter proximal to the takeoff.
So size the stent to the smaller downstream vessel. Why is that so important?
It's critical to prevent carina shifting. If you choose a stent diameter based on the larger proximal vessel, that oversized proximal part of the stent will physically bulge into the bifurcation area.
Pushing on the divider.
Exactly. It pushes the carina, that wedge of tissue dividing the MB and SB, directly into the opening, the ostium of the side branch. This mechanically squeezes the SB origin shut. Sizing to the smaller distal reference diameter avoids this proximal stent overexpansion and protects the SB ostium.
Got it. Rule number 3.
Rule 3. Minimize dissection. We've touched on this, but it's worth repeating as a core rule. When a significant side branch is involved near the CTO, you need to make every effort to use techniques that achieve true lumen tracking.
Prioritize staying inside the original vessel path.
Yes, because, as we discussed, extra plaque tracking is the primary cause of the most severe complications, like irreversible SB occlusion due to flat formation or subintimal shift. The consensus is very clear. Be extremely cautious with dissection and reentry techniques near important bifurcations.
And the final simple rule.
Rule 4. Optimize using POT. After you've placed the main branch stent, you must perform the proximal optimization technique.
POT, what does that involve again?
It involves inflating a short, appropriately sized, non-compliant balloon in the main vessel stent, just proximal to the side branch takeoff.
And the purpose.
2 main goals. First, it ensures the stent struts are perfectly pressed against the vessel wall, proximally good apposition. Second, and crucially for bifurcations, it flares the proximal end of the stent and specifically opens up the stent cells that are facing the origin of the side branch.
Making it easier to get back into the SB if needed.
Precisely. A well-executed POT makes subsequent rewiring of the SB, should it become necessary for the provisional strategy, much easier and safer. But the positioning is key. The distal end or shoulder of the POT balloon must be proximal to the carina. You don't want the POT balloon itself pushing on the carina or extending into the SB origin.
Okay, those 4 rules seem like a solid foundation for the provisional approach. But you mentioned sometimes provisional isn't enough. When does the strategy shift towards planning for 2 stents right from the outset?
Right. While provisional is the default, the experts emphasize that systematic 2-stenting planning to stent both branches from the start is only truly needed in a fairly small percentage of cases. They caution against doing it routinely.
But there are specific situations where it's justified.
Yes, the consensus highlights 2 main scenarios where deciding on an upfront dual stent strategy using techniques like T-stenting, culotte, or T-EP makes more sense.
What's the first scenario?
Scenario 1 is all about access difficulty. Let's say getting that initial protective wire into the side branch was incredibly difficult. Maybe the SB takes off at a very sharp angle, the origin is heavily calcified, or it was just really hard to see. You might have needed special wires, microcatheters, maybe the reverse guide wire technique we'll discuss later.
So if getting in was a battle,
then you really don't want to risk losing that access. Trying to rewire a previously challenging SB after the main vessel stent is in place, potentially through distorted stent struts, is a very high-risk maneuver. In these cases, the consensus is that it's safer to secure that hard-won SB access immediately with a stent as part of a planned 2-stent approach, rather than risk a difficult or impossible rescue later.
that makes sense. Preserve the access you fought for. What's the second scenario for Plan 2 stenting?
The second scenario relates to the extent and severity of the disease. If both the main branch and the side branch have significant long segments of disease right at the bifurcation.
So it's clear the SB will need treatment anyway.
Exactly. If it's obvious that just stenting the main branch, provisional, will leave behind a major diseased lesion in the SB origin or body, potentially compromising flow or long-term results, then planning for complete coverage with a 2-stent technique is the better long-term strategy for the patient. You're addressing all the significant disease up front.
Okay, and there was one other situation mentioned, a sort of mandatory two-stent situation arising from complications.
Yes, the special case of extra plaque tracking. This isn't usually a planned scenario, but rather a bailout. If during the difficult process of crossing the CTO, the operator was forced to track extra plaque, and this resulted in the side branch being compromised or excluded by that intimomedial flap we talked about.
Then you have to fix it.
You have to.
Yeah.
The priority immediately shifts. First, you must regain true lumen access into that compromised side branch. Once you've successfully reaccessed the true lumen, you must stent that segment. It's no longer optional.
Why is stenting mandatory then?
Because the stent is needed to tack down that dissection flap to essentially seal the pair and keep the SB lumen open. Without a stent, the flap could prolapse back or the subintimal space could re-expand, leading to reocclusion. So in this specific situation, a complex T-stent or a full dual stent strategy becomes necessary, triggered by the complication of extra plaque tracking near the bifurcation. Now, tackling this level of complexity, especially navigating true versus false lumens near a bifurcation, really highlights the limitations of just using angiography, just looking at the 2D shadow images.
Right, you need to see inside the vessel.
Precisely. And the tool that the consensus identifies as absolutely indispensable here is intravascular ultrasound, or IVUS.
It's not just for diagnosis anymore in these cases. It's really a navigational tool. The review outlines 3 key functions for IVUS in CTO bifurcations that boost safety and success. What's the first?
The first is cap ambiguity resolution. Remember that proximal cap situation where it's hard to find the MB entry point? If you place the IVUS probe into the side branch, you get a cross-sectional view right at the takeoff. This lets the operator see the wire tip in relation to the plaque and the true lumen opening of the main vessel.
So you can steer the wire accurately.
Exactly. It facilitates what's called IVUS guided penetration. You can precisely target the entry into the true lumen, greatly reducing that initial risk of going subintimal right next to the SB.
Okay, that handles the start of the CTO.
Yeah.
What about navigating through it, especially if you do go subintimal?
That's the second major function, subintimal tracking detection and guidance. If the operator suspects or knows they're tracking extra plaque, IVUS provides invaluable information. It can show you exactly where your wire is it in the subintimal space? How close is it to the true lumen? Crucially, how close is it to the SB origin? And how close is it to the outer edge of the vessel, the adventitia, where perforation risk lies?
So it helps plan the reentry.
Yes, it's essential for planning a safe reentry back into the true lumen. IVUS helps you choose a reentry point that's hopefully distal to the SB origin to avoid compromising it, but proximal enough to have a good landing zone, and importantly, directs the reentry away from the SB and away from the external vessel wall to minimize risks of SB occlusion or perforation.
And the third IVUS function happens just before stenting.
Correct. This might be the most critical preventative step. Pre-stenting assessment. Before you deploy any permanent metal, you use IVUS to meticulously check the relationship between the channel you've created in the main branch and the origin of the side branch.
What are you looking for specifically?
You're looking to confirm, is my wire definitely in the true lumen of the MB where it passes the SB? Or did my crossing unintentionally compress the true lumen? Is the SB origin currently compromised by a flap or hematoma, even if it looks okay on angio? Identifying these issues before stenting is paramount because it helps you anticipate and hopefully prevent the dreaded subintimal shift where stenting the MB suddenly crushes the SB. If IVUS shows, for example, that the SB takes off from a compressed true lumen next to your subintimal track, you know you likely need a 2-stent strategy or further maneuvers before placing that main vessel stent. It avoids discovering the disaster after it's too late.
That pre-stenting check sounds vital. The review did note a practical point. Using IVUS, especially with some of the other tools like double lumen microcatheters, often requires a larger guiding catheter, typically an 8 French guide.
That's right. You need enough space in the guide to accommodate the IVUS catheter alongside potentially a microcatheter and wires. So it's a planning consideration right from the start, anticipating the need for 8 French access if complex bifurcation work with IVUS is likely.
Okay, let's talk about those other tools. Microcatheters are standard in CTOs for support and wire exchanges. But the consensus highlights a specific type for bifurcations.
Yes, while standard microcatheters are essential, the real game changer for bifurcation work within a CTO is often the double lumen microcatheter, the DLMC. Examples are devices like the Twin Pass, Crusade, or Fine Duo.
What makes them so useful here?
Their design gives you a huge strategic advantage. They have two separate internal channels, or lumens. This means you can park a guide wire securely in one branch, say, the main vessel maintaining that important position.
Anchor wire.
Exactly. And then you can use the second lumen independently to manipulate another wire, maybe to probe the side branch, change wire shape, or try different wires to access a difficult SB takeoff, all while your main wire position is safely maintained.
So it prevents losing position in one branch while working on the other.
Precisely. It simplifies trying to achieve that ideal lumen-to-lumen wiring, especially when the SB is angled sharply or its origin is diseased or ambiguous. It provides stability and control that you just don't get with a single lumen catheter trying to manage two wires.
The review also mentioned a very specific, almost advanced technique that DLMCs enable, the reverse guide wire technique. Sounds intriguing. How does that work?
Ah, yes, the hairpin wire trick. This is a really elegant solution for trying to access side branches that take off at an extremely sharp, almost backward-facing angle where a standard wire just wants to go straight past.
So how do you make the wire turn back on itself?
You take a relatively stiff guide wire and advance it well past the SB origin using the DLMC. Then, holding the DLMC stable, you carefully push the wire forward against some resistance distally, or use the catheter tip to deliberately prolapse the wire tip, folding it back on itself into a very tight U or hairpin shape near the end.
Okay, so you create a hook.
Exactly. Then you slowly withdraw the entire system, the DLMC and the bent wire together. As the hairpin shape comes back towards the SB origin, that stiff, curved tip can effectively hook into the ostium of the sharply angled side branch.
Wow.
It requires finesse, and the stability provided by the DLMC is absolutely essential. Without the DLMC holding everything steady, the wire would just buckle or whip around unpredictably. But when it works, it can get you into branches that are otherwise inaccessible.
Let's quickly revisit the distal cap bifurcation, the most common location. Given its inherent risks, like at the RCA crux, what's the overarching strategic recommendation?
For those challenging distal cap scenarios, the consensus often leans towards planning for, or at least being prepared for, a bilateral approach.
Meaning working from both ends.
Potentially, yes. Using both antegrade wiring from above and potentially retrograde wiring from below, coming up through collateral channels. The idea is to have multiple options. If your antegrade wire compromises one distal branch, say the PL branch, having retrograde access might allow you to save the other branch, the PDA, or vice versa. It's about maximizing the chances of salvaging at least one, if not both, important distal vessels.
And IVUS plays a role here too.
Absolutely critical here. After you think you've successfully crossed the distal cap and your wire seems to be in one of the distal branches, you must confirm its position with IVUS before stenting.
Why the mandatory check?
Because angiography can be incredibly deceptive at the distal cap. Your wire might look like it's in the PDA, but it could actually be in a subintimal track right next to it. If you deploy a stent based only on the angiogram and you're actually subintimal, you will almost certainly occlude one or both of the true distal branches. That final IVUS check confirms you are truly intraluminal before you commit to stenting. It's a crucial safety step.
All right, even with the best plans and tools, things can go wrong. The consensus document spends significant time on recognizing and rescuing the major complications specific to CTO bifurcation work. Let's start with the one linked to extra plaque tracking. Subintimal shift, or SIS. Define that for us again and why it's so dangerous.
Subintimal shift, SIS, is basically the sudden functional blockage, either total or partial, of a vessel segment, most often the side branch, that happens after you've performed ballooning or stenting in the adjacent main vessel segment, specifically when you are working in the subintimal space.
So fixing the main vessel causes the side branch to shut down.
Exactly. The enlargement of that subintimal space by the balloon or stent physically shifts tissue or hematoma, compressing or distorting the origin of the adjacent true lumen, often the SB. The danger is how quickly and unexpectedly it can happen. A previously healthy-looking SB can just disappear from the angiogram instantly after you stent the main branch.
And the rescue depends on understanding where the problem originated. The consensus talks about type 1 versus type 2 SIS.
Yes, the distinction is crucial because the mechanism and the rescue strategy are different. It all depends on where the operator re-entered the true lumen relative to the side branch origin.
Okay, explain type 1 SIS.
Type 1 SIS happens when the re-entry from the subintimal space back into the true lumen occurred at the polygon of confluence, right where the main branch and side branch meet. In this case, the SB occlusion is mainly due to the true lumen collapsing because the neighboring subintimal space got pressurized and expanded. Importantly, there isn't usually a persistent, rigid flap separating the MB and SB true lumens.
So how do you rescue type 1?
Because there's no major flap in the way, the occluded SB is often relatively easy to rewire. You get a wire back into the SB true lumen, and then usually stenting the main branch across the bifurcation helps to tack everything back down, re-expand the collapsed SB origin, and restore flow. It's still a complication, but often salvageable with reasonably standard techniques.
Okay, that sounds manageable, but type 2 SIS sounds much worse.
Type 2 is the really challenging one. This happens when the reentry into the true lumen occurred distal to, or beyond, the takeoff of the side branch.
So the SB originates from the segment you bypassed subintimally.
Correct. Now you have a major problem. The true lumen of the main vessel, where your stent is going, and the true lumen of the side branch are physically separated by a persistent intimomedial flap created during the subintimal passage.
And stenting makes it worse.
Yes. Stenting the main vessel in this situation will simply compress that flap even harder against the SB origin, permanently sealing it off. Rewiring is incredibly difficult because you have to somehow get through or around this flap.
So what's the rescue strategy for type 2?
It requires advanced techniques and usually imaging guidance, like IVUS. You might try very careful, guided rewiring, often needing a DLMC for support and control, to try and find a microscopic channel back into the SB lumen through the flap. If that fails, the next step might be to intentionally perforate the flap itself with a stiff, high-penetration guide wire, basically, creating a new connection between the stented MB and the occluded SB true lumen. This is obviously high risk, requires great skill and caution to avoid perforating outside the vessel entirely. It's a complex bailout.
Wow, okay. Let's shift to the other major mechanism of SB occlusion, the one more related to intraplaque work or stent mechanics, carina shifting.
Right. Carina shifting is different from SIS. It's
Yeah.
typically what happens when you're working within the true lumen intraplaque. It's a purely mechanical blockage caused by the stent interacting with the bifurcation divider.
And it usually happens because...
Two main reasons. Either the main branch stent was significantly oversized, proximally violating that 3-diameter fractal sizing rule we talked about, or the proximal optimization technique, POT, was performed incorrectly, with the balloon positioned too far distally, actually extending across the carina.
So the stent, or the POT balloon, physically pushes the carina into the SB opening.
Exactly. It physically obstructs the SB ostium.
Now, if this happens, the European Bifurcation Club has a recommended sequence of steps for rescue, doesn't it?
Yes, they've laid out a very logical step-by-step approach to try and restore flow when carina shift occludes the SD. Every interventionalist dealing with bifurcations should know this sequence.
What's step 1?
Step 1, absolutely critical, repeat POT. Even if you did one initially, you do it again. But this time, you ensure the POT balloon is positioned meticulously. Its distal shoulder must be just proximal to the carina, not on it or past it. The goal is to use the POT balloon to flare the stent struts facing the SB ostium, creating the largest possible opening to facilitate rewiring.
Makes sense. Open the door first. Step 2.
Step 2, rewire. Using a new guide wire, often a third wire if you still have the jailed wire in place, you attempt to carefully navigate through the now hopefully enlarged stent cell opening created by the POT and steer the wire down into the distal side branch.
Is this easy?
Not always. The anatomy is distorted by the shift. This is often where specialized tools help, using a DLMC for better wire control, or an angulated microcatheter to help direct the wire tip towards the likely location of the SB ostium through the stent struts.
Okay, let's say rewiring is proving difficult or fails. What's next? You still have that original jailed wire in the SB, right?
Hopefully, yes. And that leads to step 3, jailed wire rescue. If the SB is occluded and you can't rewire it easily, you can try to use the entrapped jailed wire itself. You carefully advance a very small, low-profile balloon over the jailed wire. The goal is to push this balloon through the crushed ostium into the SB and inflate it gently to reestablish flow.
But isn't there a risk of damaging the main stent when you inflate a balloon in the SP like that?
Yes, huge risk. That's the absolute key nuance the consensus stresses here. Before you inflate that rescue balloon in the SB over the jailed wire, you must first insert an uninflated POT balloon into the main branch stent, positioned across from the SB origin.
Why the uninflated balloon?
It acts as a scaffold. When you inflate the SB balloon, it pushes outwards against the MB stent struts with considerable force. This can easily distort, crush, or malpose the main vessel stent. Having the uninflated POT balloon sitting inside the MB stent provides counter support, like a temporary internal pillar, minimizing that deformation while you perform the essential SB rescue inflation. It protects the integrity of your main vessel result.
That's a really clever mechanical trick to prevent collateral damage. So important. What if even the jail wire rescue doesn't work or isn't possible? Are there options beyond that?
If you still can't restore flow to a critical SB using those steps, you move to step 4, advanced bailout techniques. These are basically commitment strategies when simpler methods fail. This might involve things like intentionally extending a subintimal dissection down the SB using a knuckled wire, if getting lumen-to-lumen access seems impossible and you just need to create some kind of channel. Or, in very complex situations, you might have to convert to a full, complex two-stent technique like the inverted double kissing crush, essentially rebuilding the bifurcation with stents to ensure coverage and flow, accepting that the original anatomy is lost.
So these are really last resort measures for critical side branches.
Exactly. Reserved for situations where the SB is too important to lose and the standard rescue sequence hasn't succeeded. Hashtag tag outro.
Well, this has been an incredibly detailed look at a truly complex area. We've covered the frequency, the locations, the specific dangers, the tools, the strategies, and the rescue techniques for managing CTOs that involve bifurcations. If we had to synthesize the core message from this expert consensus, it seems to be that while it's undeniably challenging, the foundational principle remains. Protect that relevant side branch, primarily using a provisional stenting strategy whenever feasible.
Absolutely. That's the bedrock. Provisional stenting, supported by those simple rules: wire early, respect fractal anatomy, minimize dissection, and optimize with POT. And underpinning all of that is the critical role of technology. We simply can't navigate these complex situations safely and effectively without tools like IVUS giving us that crucial intravascular view, and specialized microcatheters like DLMCs providing the control needed for precise wire manipulation.
They're not just aids anymore. They seem essential for understanding the lumen, avoiding disaster, and anticipating problems like subintimal shift before they become irreversible.
Right. IVUS lets you see the problem developing rather than just reacting to the angiographic consequence after it's too late.
This consensus really provides a roadmap, shifting the approach from maybe hopeful exploration to a much more guided, proactive methodology based on shared expert experience.
Which brings us nicely to a final thought, perhaps something for you, the listener, to consider further. We kept coming back to the fact that the most feared complications, the irreversible SB loss, the MIs, the nasty type 2 subintimal shift, are almost always rooted in extra plaque tracking near the bifurcation. While dissection and reentry are powerful, necessary tools for crossing many CTOs, the real frontier for improvement seems to lie in refining techniques and technologies that allow us to stay lumen to lumen more consistently, especially when navigating through or near these critical bifurcation points.
So mastering that true lumen passage is the key.
I think mastering that or developing tools that make it easier and more reliable is where the next big leap in improving outcomes for these incredibly complex patients might lie. Minimizing that extra plaque excursion near bifurcations seems paramount.
That's a powerful takeaway and a great challenge for the field. It really underscores the continuous evolution needed in these advanced procedures. Thank you for sharing those insights. And thank you, our listeners, for joining us on this deep dive into the intricate world of CTO and bifurcation interventions. Thank you for watching The Funnel Effect.